Good evening, ladies and gentlemen, and dear students. On behalf of Indian Society of Nephrology, I welcome all of you to our first session on case presentations in nephrology. So this is a unique initiative by the Indian Society of Nephrology and is targeted mainly towards students. And I am very sure many other nephrologists, practicing nephrologists like us, will also be immensely benefited by this initiative. So why this event? In this era where there are so many events going on, so many online and physical platforms, so why this event? So, what has become for all of us is that there is an explosion of knowledge, so much of knowledge, so many places, so much of information, and so many new techniques coming in, new AI coming in, and so much things changing. So we all feel as nephrologists and as students also will feel that the basic bedside teaching of seeing a patient, examining a patient, doing rounds, and discussing bedside and practical things which are day-to-day useful is actually we have to reinvent it and practice it for having a proper mix of the new things and the conventional things. And of course, for all the students, there is the added advantage that you all have to appear in your DNB or DM exam, and these things you will be asked in the exam, your clinical method. So all that will be important for you. So our endeavor from the side of ISN is to help you all out. So we will be doing case presentations on different cases, and we also plan to archive it with us. So it will all be available gradually with time in the website of ISN. So it will be freely available. You all can see and access it. And we also plan as an educational initiative that after each case, we would make a list of important questions in each case and some things like must know topics in each topic so that it becomes easy as a ready reckoner whenever you want to study. And with the conventional way, with the blessings of God and Ma Saraswati, we start our first session. And we also have Professor Shyam Bansal sir with us. I would request sir for a short message. After that, we go ahead with today's proceedings, and I will tell you about the topic. Shyam sir.
So thank you very much, Vineet. I think Vineet has already highlighted why we started this thing, and their work Vineet and Jasmine has taken, and with Dr. Arvind Kanchi has taken this initiative. And I am thankful to Dr. Gopalkrishnan, who is our scientific chairman also of Indian Society of Nephrology, to start this case presentation, and I'm sure it is going to be very helpful for all these students. So Dr. Gopalkrishnan, please. And
so I will just introduce sir. So in today's first session, we'll be doing a case presentation, and this is how we go about. There are many small doubts in nephrology, some aspects which are never actually understood by us. So our faculty Gopalakrishnan sir thought that let us clarify these doubts so that they become easy to understand. Followed by we will go ahead for a case presentation, and we'll see it later. And then subsequently we'll have a short question answer session. I would request all of you to use the chat box for that. Uh, I'm quite fortunate and quite humbled to be introducing one of my teachers, Professor Gopalakrishnan sir. Uh, Sir requires actually no introduction. All of us know him very well, and whenever we think a quite reputed or a revered teacher in nephrology, the first image which comes to our mind is Professor Gopalakrishnan sir. And sir had done his basic MBBS and MD from Madurai Medical College. After that, we all know him as the HOD of Institute of Nephrology, MMC Chennai, and he recently took over as also member secretary of the Transplant Authority of Tamil Nadu. Sir is a part of all national and international societies. In multiple appointments he has worked. Presently, he is the chairman of the scientific committee of our Indian Society of Nephrology, and we're very proud and fortunate that that our this maiden initiative of case presentation is being initiated by sir itself. And sir has got numerous awards to his credit, with more than 15 orations. And all those people who are keen for research, and we always look forward to sir. In fact, we all meet sir and clarify our doubts because he has been keenly involved in research also throughout his career for almost 30 to 40 years. And the first population survey of CKD in India was done in Tamil Nadu by a study called STEP study, which was initiated by sir. and all the many famous clinical trials which we have read, sir has been a part of it. And also, he knows the proper method to do research and has been a part of various ethics committee and research boards. He has multiple publications, and honestly, as I said, he is the ideal teacher. And I am very sure, in fact, we personally look forward to this opportunity to learn from this session. And we would keep it a very basic case presentation. Dr. Raja, who is a senior resident from Madurai Medical College, a senior resident nephrology, will be doing the first case presentation. So how we would go about is that I would request all of you to please stay muted to avoid any disturbance. Any comments, doubt, put in the chat box. End of the session, if there is some Q and any question answer, we want your comments, so you can raise your hands and we'll go ahead. We want to improve, so please send across your feedback, suggestions, comments on our personal message, WhatsApp, anything, and we'll be ready to help. So without much delay, I would go ahead to our first session, and I would request Dr. Gopalkrishnan sir to please share his screen.
Good evening, everyone. Thanks for this. I've been looking forward to this opportunity very keenly to be in touch with all the residents and young consultants, just to share the excitement which I always have had during my resident days, starting from my resident days in nephrology. In fact, why I chose nephrology as a subspecialty among all the other specialties of medicine is that, the attraction towards the renal physiology, the excitement and the intricacies of the renal physiology that is exciting me even today. I used to think whether kidney has got its own brain. Even the latest super computer cannot be equivalent to one tiny mass, one tiny highly specialized tissue called kidney. You all know kidney has got so many functions. The primary function of the kidney is the glomerular filtration. Whenever you say that somebody has got a kidney failure, you actually mean that the GFR is low. But the tubular functions are amazing. There are three important tubular functions of the nephron as well. Apart from the glomerular filtration, the filtration is the function of the glomerulus. The tubule has got three important functions, namely urinary concentration, urinary dilution, and the third most important thing, urinary acidification. In the subsequent sessions, we can discuss about the other tubular functions. Today, I thought I'll just share a few highlights about the tubular function, namely the renal acidification. Okay, and I profusely thank Dr. Shyam Bansal, Dr. Arvind Khanchi, Vineet, and Jasmine for their help and inviting me to initiate the series of discussion. So the structure of these sessions will be like this. Every session to start with one basic pearl in nephrology, to start with all renal physiological pearls. Then that will be followed by a clinical case scenario discussion in the format of a long case for DM and DR and B exam mode, and then a wide-ranging discussion later on and interactions. That's how we are planning. I may take about 10 to 15 minutes to start with. Okay. So as I've already said, like acid excretion by the kidney is one of the important functions, right? Why it has to happen? Yeah. You all know the plasma pH is 7.35 to 7.45. What is pH? pH is a negative logarithm to the base 10 of hydrogen ion concentration. You might wonder as to why this particular type of expression. Why don't we just simply say how much of the hydrogen is present, the exact quantum of hydrogen in the plasma, for instance. Look at this. What is the plasma hydrogen concentration? It is 35 to 45 nanomole per liter. So if you convert that into the moles per liter, so many zeros and all that, So that is why, to make it convenient, the logarithmic expression, logarithm-based expression of hydrogen ion concentration of fluids is commonplace. Okay, fine. What is the importance of pH? The normalcy of pH is mandatory for normal cellular function. When I say cellular function, that encompasses the whole lot of it, the enzyme activity, the hormonal functions, and, the basic metabolic machinery, and everything and anything is dependent on the plasma pH that has to be maintained. Just understand the minute range of hydrogen ion concentration in the plasma, just minute range, 7.35 to 7.45. The number may look like 0.10, but here if you convert that into moles per liter, it is such a minute range. So maintaining the pH, the hydrogen ion concentration in such a minute range is an uphill task. Why I say it is an uphill task? Let us go through the next slide. Next slide, please. Yeah. Look at the quantum of acid that is being produced every day. Every day, our body produces acids. We can broadly classify them into volatile acids and non-volatile acids. The volatile acids, huge quantity that is excreted by lung in the form of carbon dioxide. You all know carbon dioxide is an acid equivalent. So I'm not going to discuss anything about that. Look at the non-volatile acids. These non-volatile acids necessarily have to be handled by the kidney, and mandatorily they have to be excreted through the kidneys only because they are not volatile. What are they? The classical examples are sulfuric acid and phosphoric acid and so on. What is the source of that? Your endogenous metabolism and then dietary addition of acids. What is the quantum of non-volatile acid that is added to the system in a steady state? Look at this, about 1 millimole per kg per day. And kidney has to excrete. Okay, next slide. So, imagine a person's body weight is about 60 kilos, 1 millimole per kg, meaning every day some 60 millimoles will be added. So, the wide range, like 50 to 75 millimoles, an average adult of normal build. Okay, just now I have explained to you the plasma concentration of hydrogen ion is only 35 to 45 nanomole. What is the relation between nanomole and millimole? It is 10 lakh times. So the turnover is 10 to the power of 6 times, 10 lakh times. Such a huge turnover, but the plasma pH has to be maintained at nanomole level. Now you understand the task the kidneys are accomplishing. I hope you understand, right? So such a huge turnover and the constancy of such a minute range maintenance is a big task, uphill task. Next slide. So this is this one diagram explains the 3 important mechanisms of handling of acid by the body. As I've already said, when an acid is added to the system, the first thing that comes into the picture is to nullify the changes that are going to happen in the pH because of addition of acid. Immediately what comes into play is your buffers, which are readily available in the plasma. That is the bicarbonate is the most important one, then phosphate buffer, protein buffer, hemoglobin buffer, and all that. I'm not discussing that. So that is happening immediately. Next thing is that, as I've already said, the brainstem stimulated, the respiratory effort happens, and then ventilation and CO2 is exhaled. So that is happening within few hours. But the non-volatile acid, the third component on the right-hand side, it is on the kidney. So that is what we are going to see now. Next slide. Yeah. So now I request your very close attention to these pictures. Every word what I'm going to utter is important. Okay. So I said the kidneys are capable of excreting so much of acid. What is the lowest possible urine pH is 4.5. Okay, 4.5 is the lowest possible pH. Meaning the pH of the filtrate in the tubular lumen is 4.5, whereas that in the blood, there is a peritubular capillary, is 7.45, that is 7.5. If you say it is 7.5, what is the gradient? 7.5 minus 4.5 is 3. So what is the maximum capacity of the tubules to excrete acid against a gradient of 1000? 3 meaning 7.5 minus 4.5 is 3. So it is pH is expressed as unitless number, logarithmic expression to the base of 10. So 3 meaning 10 into 10 into 10. So 1000 times. So the capacity of the tubular cell to excrete acid into the tubular lumen is the maximum gradient determined by a maximum gradient of only 1000. But the turnover is to the point of 10 to the power of 6 times. How is this going to be accomplished? Even this itself is very amazing, right? There are 1000 times, the difference in the hydrogen concentration in the capillary that is lining the tubular epithelial cell tubule and the tubular lumen. Okay. Let me move on to keep this in mind, and then let me move on to the acidification mechanisms. There are two important the structures or the moieties in the renal tubular epithelial cells which cause acidification or excretion of the hydrogen ions. Concentrate on the left side picture. So that is the proximal tubule. I have just put a blue star over there, blue star. Please remember this. This is the most important structure over there, which we call it as sodium hydrogen exchanger, which is electroneutral. As the name implies, one sodium, for every sodium that is entering into the cell, one hydrogen ion is excreted from the cell into the lumen. Okay, so this is exchanger. Okay, what is the force? What is the force for sodium to enter into the cell? Because we all know on the basolateral membrane, we have 3 sodium, 2 potassium pump, which pumps sodium out of the cell and draws potassium into the cell. So when the sodium within the cell is pushed out, that favors entry of sodium from the lumen into the cell. Am I clear? Okay. So this is a secondary active process. So for sodium entering into the cell, hydrogen comes out of the cell into the tubular lumen. So it is a secondary active process. This hydrogen is excreted. Okay. Then what happens? Is it very efficient? It functions so well, but it is not efficient. Why is it not efficient? Next slide, please. Next slide. Yeah. There is something else is happening. Please remember this point and keep it aside. Now you concentrate another facet of what I am going to say. We all know the bicarb that is present in the plasma is easily filtered at the glomerulus along with sodium. So much of bicarb is just filtered. As I've already said, bicarb is a very important, readily available buffer in the plasma that comes into action. The moment acid is added, immediately it comes into action to buffer that. So if so much of bicarb is just filtered and goes off, what will happen to the system? The system will collapse. So all the bicarb, the huge quantum of bicarb that is excreted, that is filtered, has to be reclaimed, has to be reabsorbed. It cannot happen just like that. So there is a mechanism here. So this sodium hydrogen exchanger, which I have mentioned just now, that plays an important role in reclamation of this filtered bicarbonate. How is it happening? The hydrogen comes out, it complexes with bicarbonate that is filtered, which is there in the tubular lumen. That results in the formation of carbonic acid, H2CO3. And we all know there is an important enzyme in the lumen, that is the carbonic anhydrase. That carbonic anhydrase dissociates carbonic acid into water and CO2. CO2 being a gas freely diffuses back into the cell. Again, in the proximal tubular epithelial cell, within the cell, cytosol, again there is carbonic anhydrase. Here the CO2 which has diffused into the cell clumps with H2O, forming carbonic acid, which dissociates into hydrogen ion and bicarbonate. This hydrogen ion is again excreted through the pump, the exchanger. Bicarb enters back into the system. I have mentioned as bicarb reabsorb. But please remember, this bicarb is not the original bicarb that is filtered at the glomerulus. This is actually generated within the cell by the action of carbonic anhydrase. Somehow it is reabsorbed. So it is a very complex mechanism. By this mechanism only, 85 to 90% of the filtered bicarb is effectively reabsorbed or reclaimed. Okay. Now we understand there is so much of hydrogen ion is excreted by the sodium hydrogen exchanger, but has it really get rid of the so much of acid load that is pushed on the kidney? No, not at all. All this important work, all this hard work by this sodium hydrogen exchanger is utilized just for reclaiming the filtered bicarbonate. Okay. Okay. And this hydrogen ion that is entering into the lumen gets back to the cell again to reform carbonic acid. So this is only for reclaiming the bicarbonate acid. So at the end of the proximal tubule, at the maximum, the pH of the tubular lumen will drop down to 7. From 7.5 to 7, not more than that. Not more than that, in spite of so much of hard work. Then what's happening? Next, other mechanism. Now, let us talk about net acid excretion. What is net acid excretion? I'll discuss about that later. The second mechanism here is the hydrogen HATPase. Please go back to the previous slide. Previous slide, please. Yeah, the previous one. The previous one. Yeah. So on the right-hand side, you just concentrate on the distal tubule, particularly the collecting duct. I have put again as a blue star over there. There is something called HATPase pump. The HATPase pump is a active process by which hydrogen is an energy dependent. By the hydrolysis of ATP, it recuperates energy and functions. It just pushes hydrogen out of the cell into the lumen. Okay, so this is more important. This is how the net acid excretion is happening. So what is a specialized cell here? It is alpha intercalated cell. Alpha intercalated cell. It is characterized by the presence of the HATPase. Can you just recall the few tissues in the body which have the HATPase pump? One is the gastric mucosa. Another important thing of our interest is the bone, osteoclast. For instance, hypercalcemia of malignancy and so on. You know, how does it happen? The osteoclast in the bone, it liberates hydrogen ion by this mechanism of HATPase that causes dissolution of the bone and liberates calcium. That's how we know it's happening, like metastasis and so on. So osteoclast and of the bone and alpha intercalated cell of the distal tubule or collecting duct, they share a lot of common characteristics. In fact, some of the physiologists describe osteoclast as alpha intercalated cell of bone. And alpha intercalated cell is described as osteoclast of kidney. So there is so much of similarity. Why I'm saying all that is that please remember the presence of HATPase in the luminal membrane. Next slide. How it gets rid of acid. Next slide. Next slide. Yeah, this we have discussed. Next slide. Yeah, please concentrate here. This HATPase, hydrogen comes out. So there is so much of acid I've already said. All the hydrogen that is excreted is only utilized for reclamation of bicarb. So there is so much of hydrogen to be excreted. If all the hydrogen is excreted, in no time the urine pH will come down to 4.5 and there is no further acid can be excreted because the lowest, this thing is 4.5. So you have to keep the urine pH above 4.5. How is that happening? It can happen only if there is a buffer within the tubular lumen. What is this buffer? This is the monohydrogen phosphate buffer. Monohydrogen phosphate buffer, HPO4. So the hydrogen comes out, it clumps with monohydrogen phosphate, it becomes dihydrogen phosphate. Thereby, the pH is not going down too low, but favors further excretion of hydrogen. So this is the role of a buffer here. Please remember this buffer, very, very important. The acid that is excreted by this mechanism is called titratable acidity. This is a university exam question. Titratable acidity. Why is it called titratable acidity? Because you can quantify the amount of hydrogen that is excreted by this mechanism by back titration, meaning by addition of certain amount of a strong alkali like sodium hydroxide to bring back the urine pH to 7.5. How much of alkali is required to elevate the pH of the urine to 7.5? That is the measure of this. So this is titratable acidity. Usually it is contributed by this mechanism. Okay, so this is very efficient mechanism of getting rid of hydrogen. But again, it has got limitation. What is that limitation? Once this buffer gets exhausted, no further hydrogen can be excreted. Where is this buffer coming from? It is coming from the glomerulus. Again, it is filtered. So this monohydrogen phosphate is filtered at the glomerulus. It does not have an infinite capacity. It has got a finite capacity. So what is the maximum amount of hydrogen that can be excreted by this mechanism? Up to 30 millimoles. Only up to 30 millimoles. But I already said 1 millimole per kg body weight is in the steady state it is produced. So even this efficient mechanism also is not enough, not sufficient. Then how is it happening? And please remember this. What's happening here is the hydrogen comes out, dihydrogen phosphate. How this hydrogen comes out here? Within the cell, the CO2 and H2O by the action of carbonic anhydrase, H2CO3 is formed and hydrogen comes out and bicarb goes in. Please remember, this bicarb is not a reclaimed bicarb. It is a generated bicarb. The difference of bicarb entry back into the system from previous section is different. This is not a reabsorbed option of the already filtered bicarb. It is a generated bicarb. Fine. So by this mechanism, only 30 millimoles of hydrogen can be removed by this process. But it is not enough. But how is it happening? Next slide, please. Here comes the next most important and most efficient mechanism of getting rid of acid, that is by the action of ammonia. Okay. Ammonia is synthesized in the renal cells, particularly in the proximal tubular epithelial cell. For convenience sake, in the adjoining cell it is described, but it is this. Just imagine this the cell, the second cell that is depicted is a proximal tubular epithelial cell. What is the source of ammonia production? Is a glutamine. It is acted upon by glutaminase. The resultant formation of ammonia. This ammonia enters into the tubular lumen. It is not filtered. Whereas hydrogen phosphate is filtered, so it has got finite capacity. Whereas this buffer, it is not filtered. It comes from where? It comes from the renal tubular epithelial cell, particularly proximal tubular. There is so much of ability for the cells to produce this, right? So it enters into the tubular lumen, and the same mechanism, CO2, H2O, carbonic anhydrase, carbonic acid, hydrogen produced, bicarb goes into the back into the system, and hydrogen comes out. This hydrogen immediately complexes with ammonia, resulting in ammonium formation, thereby buffering, and the pH is not lowered below 4.5. So you can keep on secreting more and more. So the protonated to ammonia, it has got unlimited capacity because this buffer is a generated buffer. Okay, next slide. So there are three important functions. Please recollect this order in a nutshell. In the proximal tubular epithelial cell, it is by the sodium hydrogen exchanger, but by this mechanism, the reabsorption of all the bicarbonate buffer that is filtered in the urine only happens. It is not net acid excretion. What is net acid excretion? The acid that is excreted by the tubule epithelial cells, beyond that is required for reclamation of bicarb. That is what is a net acid excretion. That is happening by two buffers, with the help of two buffers. One is secretion with filtered buffers like phosphate, which we call it as a titratable acidity. The other one is with the manufactured buffer ammonia. Okay, fine. Okay. And this ammonia that is synthesized in the proximal tubular epithelium comes down to all the segments of the nephron. And as you go by the other segments of the nephron, production of ammonia is not that great as in proximal tubular epithelial cell. But whatever is generated and diffuses out of the proximal tubular epithelial is very much available in the distal tubule. Okay, it is very much available. Does not get altered. Okay, fine. Next slide. So what are the clinical applications quickly? Let me go through the clinical applications. One is, we all know that acidosis is an important complication of the kidney failure because acidification does not take place. Number one. Number two, another important function. With a dwindling number of surviving nephrons, what happens? The acid load remains the same. So per nephron, the amount of acid that has to be excreted becomes more and more. So the surviving nephron tries to synthesize more and more ammonia to get rid of the extra acid. What is the result? Ammonia can by itself can cause complement activation, bring in a lot of cytokines, and that causes acceleration of the renal injury. That is why we all give soda bicarb. By soda bicarb supplementation, it can retard the progression of CKD by this mechanism because you are relieving the acid load that is thrust upon the surviving nephron. Next slide. Second clinical application. Third clinical application. A few words about renal tubular acidosis. This is a big topic. I will not talk about that. What is renal tubular acidosis? Here, the dissociation of function between the tubule and glomerulus. Glomerulus is perfectly all right. Perfectly all right. There is no kidney failure, but it's isolated renal tubular dysfunction, and that too only acidification problem. So if the pathology, if the problem, the functional dysfunction is in the distal, it's called distal RTA. The functional dysfunction is happening in the proximal tubule, it's called proximal RTA. In proximal RTA, the tubular dysfunction happens, so bicarb is just wasted. So much of bicarb is not wasted, it's not reclaimed. Okay, that is why the bicarb requirement in proximal tubule, the proximal tubular renal tubular acidosis is greater than in the distal renal tubular acidosis because there is so much of bicarb that is filtered that is not reclaimed. Okay. A very classical example of a systemic disease associated with the distal RTA is your Sjogren's syndrome. In Sjogren's syndrome is the autoantibody to the HATPase, which I showed in the distal tubule. So that causes specifically knocks out that distal located distal tubular location of the HATPase, and that results in this thing. Okay, next slide. Yeah. So how to test the urinary acidification? Okay. In clear-cut case of distal RTA, you don't require this. In incomplete forms of distal RTA, you have to confirm by these tests. What do? You induce acidemia, you acid load a system, you acid load in spite of bringing the pH lower. If your urine pH is not reducing to less than 5.3, you call it as distal RTA. What do? Ammonium chloride loading test. The other one is furosemide fluorocortisone test, which is FF test. Next slide. Next slide. Yeah. Ammonium chloride test. Baseline. How do you perform? You do a baseline urine pH that will be high. Give oral loading of ammonium chloride. The dose is very important here. 0.1 gram per kg. That is 100 milligram per kg. Okay. Once it is taken in, it's very difficult to most of them vomit because the taste is very, very unpleasant, and it is put in gelatin capsules. One has to be extremely careful in measuring the weight because catastrophes have happened with this test because acid cannot be got rid of, and if you induce severe acidemia, it can be catastrophic. You have to be extremely careful. 0.1 gram per kg and put into the gelatin capsules. It has to be taken over 0 to 1 hour along with fruit juices and so on. There are certain prerequisites and all that. I will not discuss that. So what's happening? Just the physiological basis in the context of what I have said. So in these GIT, in the stomach, it dissociates, ammonium dissociates into ammonia and hydrogen. So by giving ammonium chloride, you are adding hydrogen to the system. So you are inducing acidosis, acidemia. Okay, then start measuring the urine pH hourly from 2 hours, starting from 2 hours, maximum up to 8 hours. Some books say only 6 hours. It has to come down to less than 5.3 because you have induced acidemia, more acid has to come out in the urine. If it is not happening, it is distal RTA. Next slide. As simple as that. And so this is interesting. So why this dose is important? On what basis it is 100 milligram per kg? As I've already said, every molecule of ammonium chloride yields one hydrogen molecule because NH3 plus chloride H plus, right? So one molecule. So molecular weight of ammonium chloride is what? 14 for N and 4. 1 into 4 for hydrogen, 4 hydrogens, chloride 35.5, so it's 53.5. Okay. So for every 100 milligram per of ammonium chloride, so you get 1.87 millimole. So roughly 2 millimole. So 2 millimoles of hydrogen is added per kg. What is the endogenous acid production? 1 millimole per kg. So you are giving twice the upper limit of normal addition of non-volatile acid by this test. So this is the physiological basis of the dose of ammonium chloride in that. Okay, next slide. Next slide. This is very unpleasant, difficult to perform. So nowadays, this FF test, this is important again in the exam point of view. The FF test, how is it happening? Right? Furosemide, fluorocortisone test. What is the basis of this? How do you perform this? Again, you do a baseline urine pH, give oral furosemide 40 milligram and fluorocortisone 1 milligram. F and F. How does it test the urinary acidification? So what's happening? When you give furosemide, what does it cause? It causes increased sodium delivery to the distal tubule and increased chloride, because it inhibits the 1 sodium, 1 potassium and 2 chloride pump in the medullary thick ascending Henle's loop. So more chloride in the tubule, so more electronegativity and increased sodium delivery to the distal tubule. So in the luminal electronegativity, it stimulates the HATPase. Okay, it's a positive, right? To secrete hydrogen ion. That stimulates the HATPase. Not just that, when the luminal higher sodium concentration, that sodium, the concentration gradient between the lumen and the cell is more, so that drives sodium into the cell. That also favors for hydrogen to come out. Okay, so by these two mechanisms, there's a stimulus for the HATPase to act. So you measure pH every hourly up to 6 hours. If the pH does not fall to less than 5.3, you can make a diagnosis of distal RTA. So with this, few clinical applications. Finally, net acid excretion, as I've already said, the definition of net acid excretion, the acid that is excreted by the kidney beyond that is needed for reclamation of filtered by cough. This is net acid excretion. And titratable acidity is amount of strong acid to be added to urine to bring it to pH 7.1. Usual contributor is phosphate and sulfate. So net acid excretion is two. One is titratable acidity plus the acid that is excreted with the help of ammonium buffer. So in the exam point of view, after getting amazed by this wonderful physiological machinery of acidification, examination point of view, it can be in the different formats, describe the urinary acidification mechanism, and then the mechanisms of distal RTA or proximal RTA is a very common question. Number one. Number two, short notes, titratable acidity is one, net acid excretion.
Thank you, sir. You have made this complex topic look very easy.